I am Dr. Teresa LaMasters. I'm the Medical Director for UnityPoint Clinic Weight Loss Specialist in Des Moines, Iowa. I'm the session co-chair with Dr. Kirian. Thank you for joining us today for the session. The previous speakers have done a great job discussing medications used for weight loss in detail. I've been using medications in my bariatric clinic for the past 4 years, and I'm going to take you through some real-world case examples of use of medications in practice. These are my disclosures. I have been a speaker and faculty for these 4 companies. None of these should impact my talk today. I do plan to use a couple of trade names along with the generic name for some of the cases, just because clinicians may be more familiar with the trade names, but I have no financial interest in those companies at all. So my objectives today are to discuss clinical examples of use of these medications, both before and after bariatric surgery for additional benefits. So for this case, this is going to be a case of using medications prior to surgery for optimization and then continuing on post-surgery use as well. So this is a case of a higher BMI patient, a 42-year-old female who started with a weight of 341 pounds and a BMI of 51.8. She had multiple comorbidities. She had metabolic syndrome, centralized obesity. She had prior blood clots, sleep apnea, and really severe depression. She had even required ECT therapy, and she was on 4 medications, but was now really well controlled. So she was actually started on metformin 1,000 milligrams daily and lifestyle management and optimization. Over the next 6 months, she lost 22 pounds. Bringing her down to a BMI of 48.5 with a 6.5% total body weight loss with the medication. She actually did that piece with her primary care provider before presenting to our office. So at the time of surgery consultation, her weight was 319 pounds with a BMI of 48.5. She definitely wanted a sleeve gastrectomy, and I discussed with her realistic weight loss goals of losing about 103 pounds or 60% of excess body weight. Her personal goal was to get lower than that, down to about 190 pounds. And so she wanted to get down to about a BMI of 28.9 or 75% of excess body weight loss. So we discussed that that's certainly possible with a sleeve gastrectomy, but not as likely. But she definitely wanted a sleeve gastrectomy. So we did some further lifestyle modification, and we started some semaglutide, or the trade name is Ozempic, at a low dose, because hunger and portion control were definitely part of her concerns. So by the time we got to her pre-surgery scheduling visit, her weight had come down to 292 pounds with a BMI of 44.4. With adding that semaglutide, she had lost an additional 27 pounds, or 8% of her total body weight. So she had lost 49 pounds in preparation for surgery, or 14% of her total body weight. She did notice, though, that she had increased reflux symptoms and nausea when her semaglutide dose got up to 1 milligram a week. We decreased the dose down to the 0.5 milligram a week, and she was tolerating that really well. So she had her surgery. She had a laparoscopic sleeve gastrectomy with hiatal hernia repair and no complications. I did know at the time of surgery, I do intraoperative endoscopy, and she really had fairly significant gastritis. So I start patients on a proton pump inhibitor prior to surgery, anticipating some gastritis, especially post-surgery, and continue it usually for 6 months. But because she had significant gastritis noted on her endoscopy, I actually increased that to twice daily dosing. At her 7-week follow-up visit, she had lost 45 pounds since surgery with a weight of 247 pounds and a BMI of 37.5. So she was actually down 94 pounds already since she started this whole process. In the early post-op period, we actually stop most weight loss medications in the first 6 weeks as patients are adjusting to their new diet. They're getting through the nausea and spasms that are common early after surgery. So at the 7-week visit, we went ahead and okayed her to restart her semaglutide. But at her 3-month visit, she was having a lot more epigastric pain, increased gastritis symptoms, and nausea. So she also reported some palpitations. All those can be common with GLP-1s. So we stopped her semaglutide and added an H2, and her abdominal pain and her nausea resolved. And then post-surgery 4 months, she was down 82 pounds, 57% of excess body weight loss at that point, down to 210 pounds. But she was actually down 131 pounds since starting this whole process, including her pre-surgical optimization. So her BMI was 31.9. She was really anxious to restart the semaglutide because she felt like it was so helpful for her before surgery. But I did talk to her about starting it back at the lowest dose at the 0.25 milligrams and keeping it there. Because with surgery, we're already augmenting the GLP-1 pathway. And so even a very small dose can actually have a big effect. So she was willing to give that a try. So this is a graphic representation of how her weight loss and surgery went. So before surgery, she's up here at 341 pounds. At her pre-op weight, she's at 292 pounds. And then at 6 months post-op, she's down to 186 pounds. And that BMI of 28.3, which was right about her target. I would expect her to actually continue to lose a little bit more. We also discussed that she's likely to have a very small amount of weight regain. So she plans to hopefully maintain around this range long term. So this is a case of a sleeve that had initial expected weight loss, but then weight regain. And so she needed some post-op rescue. So you can look at the details a little bit more on your own, but basically her pre-starting weight was 260 pounds with a BMI of 40.7. Her lowest weight achieved was down to 185 pounds. She lost 75 pounds with a BMI of 29, which is right around 29% of total body weight loss and 65% of excess body weight loss. So she definitely had expected results. But 3 years post-op, she started to have weight gain. And so her weight had come up to 221 pounds. She had gained 36 pounds. So almost half of what she had lost. But she had maintained 39 pounds of weight loss. And her excess body weight was now at 34.2%. So she had polycystic ovarian syndrome, migraines. She'd had a little elevated vitamin A in the past. So what's our intervention for her? Well, first we started metformin, and that helped her lose a little bit of weight. That definitely helped for her blood sugars. Then we increased the dose of the metformin. A couple months later, she actually had gone up in weight. So then we started phentermine at a low dose. 2 months later, she was losing some good weight now at 16 pounds of weight loss. We continued the same plan. 2 months later, she was really maintaining, not losing a lot, but we stayed at the same plan. 4 months later, she had actually gained some weight. So now we added some low-dose topiramate on top of this. And then at 3 months later, she had lost 21 pounds. She really noticed the benefit with the topiramate. So we increased the topiramate. That improved her migraine significantly, and her weight was down to 181 pounds. So she lost 27 pounds additional weight when we added the topiramate. So now she's 5 years out from surgery with a weight of 175 pounds and a BMI of 27.4. So she lost 46 additional pounds with the addition of medications and was able to reach below her initial post-surgery weight. So this is what that looks like graphically. So just another really good example of someone who may have been defined as a weight loss or weight regain kind of failure, but was able to be rescued with medications. In this case of a post-sleeve gastrectomy patient who also had some weight regain later. So this is a 63-year-old female with an initial BMI of 37. So the lowest weight she achieved was down to 150 pounds, which is a BMI of 24.6 and about 65% of excess body weight loss. She kind of disappeared for about 9 years. She had some weight regain, and when she came back at 10 years post-op, her weight was 182 pounds with a BMI of 29.8. She still was better off than her original weight at 226, but she wanted to recapture her initial weight loss. So what is our intervention for her? So she had also diabetes, and her A1C had recently been going up. She had asthma, she had glaucoma, she had depression, and some metabolic syndrome. So we went back to our GLP-1s, and we had her monitoring her blood sugars closely. 4 months later, her A1C had come down to 5.9. She'd lost 12 pounds. So we continued the metformin and the semaglutide, but she was complaining of fatigue, so we added phentermine. and that helped. She lost another 9 pounds. And then when we followed up with her later, she was doing really well on the metformin and the semaglutide. So we moved the phentermine to PRN use. So now she's 11 years post-surgery and 9 months post-medication intervention. She's taken the semaglutide and metformin, and her weight is 149 pounds. She's lost 77 pounds since her pre-surgery weight and 33 pounds after medications were added. So again, we were able to recapture her initial weight loss and bring her back down to where we would have expected her to be post-surgery. And remember now, she's 10 years out after surgery, and she's doing very, very well. So this is my last case. I want to demonstrate that it's not just sleeves who have weight gain. This is a post-bypass who initially had a good response with subsequent weight regain. So she's a 59-year-old female who'd had a prior lap band, and I removed that and then converted her to a laparoscopic root-gastric bypass. Her pre-bypass weight was 249 pounds with a BMI of 40.8. Her lowest weight achieved was 143 pounds. She actually lost 106 pounds, which was outstanding, 96% of excess body weight loss, and a BMI of 23.4. 7 years later, she'd had some weight regain. She was regained 59 pounds from her lowest weight. So again, more than half of her total initial weight loss. Her excess body weight loss was now at 42.7%. So again, by a lot of people's definition, this would be a quote failure. I would say a continuation of disease, demonstrating some weight regain. Now she had sleep apnea. She had 1 blood pressure medicine, some depression and anxiety. So what's our intervention for this patient? Well, some of her biggest complaints were hunger and fatigue. She did have some gastritis, so we treated that with a proton pump inhibitor and started some phentermine. 3 months later, she admitted she'd only taken the phentermine for 2 weeks. She didn't like the side effects. But she was willing to try it again now. So we restarted it at a lower dose. 2 months later, she was actually gaining weight. So we increased the phentermine and started some low-dose topiramate. 2 months later, she was at least maintaining, lost 2 pounds. We added the GLP-1s now, so started the liraglutide. It's usually not my first choice for bypasses, but it did help her with her hunger. Continued the topiramate and stopped the phentermine because it really didn't seem like it was helping her. We continued the GLP-1s at her next visit because she was starting to lose some weight, and increased the topiramate dose. 3 months later, she was actually doing really well now and had lost 14 pounds, and she felt that the topiramate helped with cravings, especially for her diet soda, which was hard for her to give up. So 3 months later, she was down 69 pounds since her bypass. At 9 years post-bypass, after initially losing 106 pounds and regaining 59, with medication intervention, she was able to lose an additional 27 pounds. So we were able to get her down to 180 pounds with a BMI of 29.5, 63% of excess body weight loss, and 27.8% of total body weight loss. Some other changes we were making is we changed her metoprolol for her blood pressure to diltiazem because the metoprolol was exacerbating her fatigue, and that really helped as well. But she felt that the topiramate especially helped for changing her taste cravings, and that the liraglutide helped with appetite and fatigue, actually both. So again, this is the graphical representation of that. And this is a great example of bypasses also have weight regain post-surgery. And sometimes we scratch our head on what to do with them. This is a great way to re-engage them. So here are my take-home pearls. Medications can be very helpful in combination with surgery for treatment of severe obesity, remembering this is a chronic disease. Metformin is great to offset the weight gain that comes with a lot of mental health medications and is usually well tolerated. The GLP-1s, the liraglutide and semaglutide, both help appetite control and metabolic syndrome. They have some taste alterations which are helpful and help with portion control. It's important to tell patients that though, or sometimes they try to kind of out-eat it and then they end up with nausea. So helping them understand it's supposed to help them eat less. Phentermine can help with sweet cravings and fatigue and is great to combine with topiramate because topiramate sometimes has brain fog and the phentermine stimulus can offset that. Topiramate really tends to help with sweet cravings, taste changes, and people who suffer with headaches. Wellbutrin can be outstanding for people who need some help with mood, fatigue, and some cravings help. And naltrexone can also help in combinations, especially with cravings and snacking. So I just want to suggest that we consider medication intervention and lifestyle modification. We also use a lot of cognitive behavior therapy for some patients prior to considering surgical conversion or revision. So in many patients, we can achieve similar results to a revision or conversion. And it just gives us more options for later treatment of their disease because we are treating a chronic disease. So I have some acknowledgments for my outstanding PAs who also do a lot of medical management in our clinic, and they help pull together the case data for these presentations. So I'm excited to have our conversation later and to answer questions. Thank you for your time and attention.